Dysplasia in inflammatory bowel disease is something that is encountered not frequently, but it is a potentially serious problem because the risk is much higher for these patients than for normal patients. So some sort of a pattern to watch over them is worthwhile. It's estimated that for ulcerative colitis, the risk goes up about 1% for every year that they have the disease. Now, we use a classification system here that helps to guide management, and I'll talk about this in a minute. So they're either flat or elevated. And when dysplasia is present, it's often multiple foci. So the time sequence seems to be uniform in that there are multiple foci that develop it. We use this grading system: negative, indefinite, high grade or low grade, although this is still a problem for most pathologists, reproducibility. It's a difficult diagnosis to make because of the background inflammation that can also mask the appearance of the cells and make it difficult to say, is this reaction or is this true dysplasia? So again, it's sometimes high power, high magnification to see, are these really dysplastic nuclei or is this just a reaction? Here, for example, it's helpful to compare more normal appearing areas like this with the dysplastic areas over here. You can see the hyperchromasia, enlargement of the nucleus, and the loss of polarity here. This would still probably be low-grade dysplasia because the nuclei are mostly pencil-shaped, thin and elongated. And oftentimes there will be some associated architectural changes as well. So finding some complex architecture like this can be very useful. Here's a high magnification to show this loss of polarity in the mucosa. But are these pencil-shaped nuclei or are they round nuclei? It's hard to tell. Probably most people would say they're still mostly stratifying and pencil-shaped. But if you look closely, you can begin to see one or two that may be rounding up. So does that make it high-grade dysplasia? You see where I'm going. There are a lot of issues with dysplasia. This is what I'm talking about. The change from pencil-shaped to round is a transition. It's a gradual one. It's a spectrum. And so there's no defined cutoff that says, you know, 1 out of every 2 nuclei has to be round before it's high-grade dysplasia. We don't have that criteria. So this makes it poorly reproducibility right here. Architectural changes, what defines them? You have the underlying distortion related to inflammatory bowel disease. Is that dysplasia? Or does it have to become more complex than that before it's dysplasia? We grade on the highest grade area that we see. Does that mean 1 rounded nucleus in 1 gland? Or does it mean 2 glands involved by high grade? Or 3? There's not criteria here. Okay? There are good practices. There is a sort of a best sense that this looks like it's going to be high grade, but it's somewhat subjective, and therefore it's not reproducible from me to you, to you, to you, because we've got this list, and everybody follows this list of features. That's not the way it is right now. On the other side of things, differentiating between normal and low-grade dysplasia, this indefinite for dysplasia is usually areas where you still have active inflammation. And it's difficult to tell whether it's the inflammation versus dysplasia. A lot of people have been working on this, and so there's some new possible tools. One is the immunoperoxidase staining for either racemase or TP53 have been proposed as ways to identify high-grade dysplasia. They look promising, but again, we've seen that before in other studies. So I think the jury is still out here in terms of whether this is the way to go. But in questionable cases, it might help. The whole management of dysplasia is also somewhat variable. It's different criteria in Great Britain versus in the United States. So let's talk a little bit about what we do with this. And then this is also a difference in management, whether it's a flat dysplasia or whether it is a dysplasia-associated lesion or mass. So that's the acronym that you'll see in the literature. So for flat dysplasia, no visible lesion, microscopic dysplasia only, the treatment generally is colectomy. When they do a colectomy, a large proportion have already invasive cancer, either near or somewhere in the sample. And this is proportional to how high the grade was and how many biopsies showed dysplasia. So if I just have one biopsy, low, medium grade dysplasia, well, I'm probably going to be a lower likelihood of cancer. But if I have high grade dysplasia in multiple biopsies, then much higher chance that there will be invasive cancer there. So from that, most authors at this point recommend that surveillance begin about 8 years after initial onset of inflammatory bowel disease. And the surveillance includes biopsying all 4 quadrants every 10 centimeters of the mucosa. That's the criteria. Now, is that foolproof? No. We could miss a lot of things that way. On the other hand, when we have a lesion or a mass that has dysplasia, many people will say these can be treated just like polyps of people without inflammatory bowel disease. So this is fairly conservative. This is fairly radical in terms of treatment. So here's kind of a graphic of the follow-up. No dysplasia, then they get rebiopsied or repeated in 2 years. Indefinite, probably negative, probably positive. Well, we repeat it sooner than that. And then low grade versus high grade, flat versus polypoid. Again, decision trees there. And then to look a little bit more closely at this flat versus lesion, there are a couple of areas where you can do polypectomy alone, whereas if it doesn't look like an adenoma or if it's definitely high-grade dysplasia, it's going to go to colectomy. Now, low-grade dysplasia probably should lead to increased surveillance or colectomy if it looks like it's fairly extensive. I'm not going to go through in detail the surveillance recommendations. I've printed them in the slides here so you can know kind of what these criteria are. This is the US surveillance guidelines. Took 2 slides to get them all on. So there's a lot of things. For example, patients with sclerosing cholangitis should have their surveillance begin almost immediately. Whereas we said 8 years for most of the others. And ideally, they do the colonoscopy when things are quiet, when they've got the inflammation under control and the patient's symptoms are fairly mild. The British Gastroenterological Association has slightly different guidelines that are present here, and maybe the Vietnamese Gastroenterology Association can make up their guidelines at some point in the future.